So my second talk at the World Congress on Cancers of the Skin was directed towards a pathology audience, and it was titled Pitfalls in the Diagnosing Melanocytic Tumors and How to Avoid Them. So these were tips principally driven at, directed towards pathologists, and I gave an overview of some of the nuances of melanoma, classification of pigmented tumours that have really changed over the last decade and were consolidated in the 4th edition of the WHO classification of skin tumours, which was released in 2018, of which I was one of the editors. And in particular, it identified a number of new tumour entities, and one of which I discussed during the course of my presentation, BAP1 inactivated melanocytic tumours. And so basically in this talk, I highlighted 4 uncommon but challenging benign tumours that are at risk of being overdiagnosed as melanoma, and I summarised the important features of 2 melanomas, uncommon types of melanomas that are prone to be under-recognised or misdiagnosed and reported as benign tumours or not even recognised as tumours. So the 2 benign tumours that I highlighted, one is a recently described entity called BAP1 inactivated nevus, and the second one was deep penetrating nevus. So the first one, BAP1 inactivated nevus, this is it usually occurs as a type of nevus that forms in association with another nevus. So it's what we call a common type of combined nevus, in which there are some small banal common nevus cells associated with some larger epithelioid, somewhat spitzoid melanocytes. So 2 cell populations, one big cells and one small cells. And what we've recognised in recent years is that the population of larger epithelioid cells has actually arisen from the associated nevus cells. So these larger cells arise because one of the benign nevus cells, which usually has a BRAF mutation, develops a second genetic hit, which causes loss or inactivation of BAP1, which is a gene that's present on the short arm of chromosome 3. And when you get inactivation of both arms of that gene, it causes proliferation of this particular cell that's got the second hit, and a new population forms. And this new population has a different morphology composed of these large epithelioid, somewhat spitzoid cells, which is often associated with some mild nuclear atypia, some occasional mitoses, and some associated lymphocytes. So they're the characteristic histological features. It often presents as a papular or dome-shaped lesion. And with that morphological appearance, it should raise the possibility of this diagnosis to the pathologist, and it can be easily confirmed with the use of immunohistochemical staining for BAP1, which shows loss of staining for BAP1 within the larger epithelioid cells, but preservation of staining both within the associated lymphocytes and the smaller banal dermal nevus cells. These tumours are important to recognise for a number of reasons. First of all, the second component represents a step in neoplastic progression towards melanoma. They're not melanoma at present. You can get melanoma that forms through this pathway, but we recognise that by the presence of greater degree of cytological atypia, more pleomorphism, more frequent mitotic activity, so morphological features of melanoma. So that's one reason these lesions are important and important to distinguish from melanoma. The second reason is that they can be a marker of hereditary cancer predisposition syndrome, which is associated with a germline BAP1 mutation. So when pathologist or a clinician identifies a patient with one of these lesions, they should always consider the possibility, could this be a marker of this cancer predisposition syndrome, which is associated with an increased risk of developing melanoma, cutaneous melanoma, but also uveal melanoma, mesothelioma, renal cell carcinoma, and a variety of other cancers, including some other skin cancers. So if the patient has multiple of these BAP1 inactivated nevi, or melanocytomas, as it's proposed they be called in the 5th edition of the WHO classification, or that they have one of the other cancers or more of the other cancers associated with this syndrome, it may be pertinent to take a clinical history and potentially get germline testing done. So that was the first lesion that I discussed. The second one is actually a very similar tumour, the deep penetrating nevus. Again, that actually occurs when a second genetic hit occurs within a banal nevus cell, and a new population of cells forms that starts to grow and has a different morphology. This one is composed of predominantly fusiform and some ovoid and epithelioid cells with intranuclear inclusions and pigmentation associated with it. But in contrast to the BAP1 inactivated tumours, these ones occur because of activation of the beta-catenin pathway, and that's where the changes in morphology occur, reasons why they occur because of activation of that particular pathway. Again, they can progress on to melanoma, but in most cases, that's not what happens. So if you like, it's been suggested that the risk of a benign nevus transforming to melanoma in a patient is roughly 1 in 10,000 per year. I don't know exactly what the risk is for one of these deep penetrating nevi or BAP1 inactivated tumours, but it's likely that the risk of transformation is orders of magnitude higher. It might be in the order of 1 in 100 or 1 in 1,000, but higher than the benign nevus. So I think that's an important concept. So there are the two benign lesions that I highlighted. They're at risk of being overdiagnosed as melanoma because there's two melanocytic cell populations present within a single lesion. So melanoma can arise in association with the nevus. So because of the second cell population and because they often do show some nuclear atypia to the untrained observer or someone who's not aware of these particular entities, they may be at risk of being overdiagnosed as melanoma.